Our first speaker is Hazel Taylor. Now, Hazel has actually pre-recorded her presentation. Hazel is a specialist registrar here in oral surgery, Salisbury, and she's been a driving force in the move forward to improve the quality of oral healthcare that we provide here in this hospital. And she undertook an audit at the beginning of this process, which she'll be presenting as part of this presentation. She's also written most of the paperwork for our healthcare quality improvement programme. So if we start off with Hazel Taylor, and hopefully the pre-recorded presentation will work automatically.
Hello, my name is Hazel Taylor. I'm sorry I can't be with you in person, but it's a privilege to be able to share some of the work we've been doing here in Salisbury. I'm going to very briefly be speaking to you about the oral care project we've been working on. We'll share some of our findings, explain what our experience has been in setting up this mouthcare quality improvement project, what some of the challenges have been, and where we see this going in the future. Our project started with an audit that was carried out last year, looking at the oral health and oral hygiene of inpatients. We know that oral health is important for physical, psychological and social well-being, and it's important for maintaining quality of life. We also know that there's a link between oral health and systemic health, and yet all too often, mouthcare in the hospital is overlooked. The NHS Essence of Care document states that people's personal hygiene needs and preferences should be met according to their individual and clinical need, and this includes their mouth hygiene. However, we found that there were no uniform guidelines as to what exactly mouthcare in the hospital should look like. The audit we carried out looking into the oral health of inpatients had a comparison between patients with and without COVID-19. Although we could not draw any definite conclusions about the role of oral health in COVID-19, our results did show that there was a need to improve the oral health for all of our inpatients. A quality improvement project was set up in the summer of last year, and we were fortunate to have the involvement of Health Education England's Mouthcare Matters team. We have found that progress has not always been easy, particularly when dealing with competing pressures on ward staff, finding time for training and balancing this project with other pulls on resources. We sampled 60 patients for our audit, half of which were inpatients with COVID-19, and we had a control group who were matched for age and length of their inpatient stay. In terms of how we assessed the patient's oral health and oral hygiene, we carried this out using observational, non-invasive assessment methods, using WHO recommended standardised reporting tools where possible. Oral hygiene was measured using the Simplified Oral Hygiene Index, which is a visual assessment of debris and calculus present on the surfaces of 6 selected teeth. We assessed the patient's DMFT score as a measure of their experience of dental decay. We recorded any soft tissue pathology using the mucosal disease section of the WHO oral assessment form, and we also assessed for dryness of the mouth. To assess gingival health, we wanted to be non-invasive and avoid probing, so we used a visual assessment of calculus, gingival inflammation and recession as a crude measure of overall periodontal health. We found that there was a wide range in the level of oral hygiene, ranging from no plaque to every tooth surface being covered. The Simplified Oral Hygiene Index mean score for all inpatients was 2.52. It was lower in the COVID-19 group compared to the control group, but 42% of our patients had a score of 3 or more, indicating very poor oral hygiene. Part of this index includes the debris index, where we saw that 58% of our patients had a score which indicated inadequate toothbrushing. When we looked into access to toothbrushes, we found that about 2/3 of our patients had their own toothbrush or had been provided one by the ward, but we did find that a number of our patients did not have access to any oral hygiene aids. Gingival inflammation was present in the majority of our patients. 52% had mild inflammation, 31% moderate, and 9% severe. This was similar across both groups of patients, although slightly more patients in the COVID-19 group had severe inflammation. In regards to other oral conditions, we found that around 1/3 of patients we examined had evidence of oral candidiasis. Other mucosal conditions included ulcers, benign vascular lesions, and white patches in keeping with friction or trauma. 50% of the patients with COVID-19 had some level of dry mouth versus 30% of patients in the non-COVID group. The caries experience was similar, with average DMFT scores of 18.5 and 17.5, and it was noted that 25% of the patients had at least one tooth with visible decay. So our audit found that there was a need to improve the oral health for all of our inpatients. When we looked into our existing practice, we found that there was inconsistency across the trust in terms of what procedures were being followed and how patients who required assistance with mouth care were being identified and cared for. Some areas had their own paperwork for assessment of the mouth and existing plans for oral care, but most areas did not. There were varying levels of quality and consistency with the mouth care that was being provided. So we wanted to make a change in the way that mouth care was being approached. We wanted to ensure that all patients who required support with their mouth care were getting this. So if a patient was unable to brush their teeth for whatever reason, this would be identified and it would become part of their daily care. If patients did not have their own toothbrush or toothpaste, this would be provided. And patients who needed specific care, for instance, those with a particular problem in the mouth or those who were at risk of aspiration, would have their care needs recorded and they would be given the additional care that they required. We shared our findings with the Trust and this led to a formal quality improvement project. The project team was made up of staff from quality improvement, from oral surgery, nurses and other staff from the wards, and those from specialist areas including end-of-life care, ITU and speech and language therapy. We also had staff who had an interest in the link between oral health and COVID, and we were lucky to have the involvement of HE staff from Mouthcare Matters from an early stage. Recently, we've also called in the expertise of our own education department to help develop the training into an e-learning format. The Quality Improvement Group has been working for several months now, developing a pathway for our patients, developing a new set of paperwork, producing standard operating procedures and policy documents, as well as trialling different products and training of staff. We do owe a huge thanks to the work of Mouthcare Matters. They were able to offer us advice and guidance, as well as providing invaluable resources in their toolkit and guidance documents which are available online. I'd strongly recommend anyone setting up a project like this or wanting to improve the quality of mouth care that they're providing to use their resources. So as I've said, here in Salisbury, there was an interest in the potential benefit that improving oral health could have on patients with COVID-19. So as part of this, all of the patients with COVID are now provided with a mouthwash containing ingredients that have been shown to be vericidal. This goes alongside advice about maintaining their oral hygiene. However, we know that improving oral health and oral hygiene can benefit all of our patients. Our pathway is that any patient who is due to stay in for more than a day would have a brief mouth care assessment, and based on the findings of this, those who need assistance with their mouth care or specific additional mouth care will have this recorded in their notes on a mouth care plan. Patients who do not have access to their own oral hygiene equipment are provided with it. Independent patients are responsible for their own mouth care, but those who require support have simple oral hygiene provided as part of their daily care provided by the ward staff. The mouth assessment is repeated on a weekly basis or if the patient's condition changes. If the patient was found to have routine dental problems, then they are advised to see their own dentist upon leaving hospital. Those without a dentist are given advice about how to register, and information is given in cases where a community dental referral is required. If there are acute or urgent problems, then oral surgery or MaxFax in the hospital can be contacted. In terms of how the project has progressed, there have been a few challenges along the way. How much additional time and resource can we ask an already stretched ward to give to assessing a mouth and looking after patients' mouths? We know that simple, quick interventions can make a big difference to our patients. And the Mouthcare Matters programme did a cost-benefit analysis and found that over a 5-year period, an oral health improvement project could generate £2.66 in cost savings for every £1 spent. However, when time, staff and resources are stretched, implementing changes such as this can be a challenge. We've spent some time modifying the paperwork that's to be used, in order to try and make the forms as user-friendly but also as useful as possible for the staff, to aid the ward staff in their assessment, recognition and management of common oral findings. We didn't want to overburden the staff. We also did not want to encourage an unnecessary number of referrals to the dental team. The existing training that nurses, doctors and other healthcare professionals get on the mouth is variable and usually quite limited. We need to ensure that what we're asking of them is reasonable, and so making sure that staff have adequate training is critical. Our initial pilot wards were given some excellent face-to-face training provided by the staff from HEE. However, providing this on a wider scale has proved problematic. Releasing staff from ward duties in order to attend training has not always been possible, particularly as autumn and winter pressures increased. we've realised that face-to-face training is not going to be the most feasible option going forward, and so are in the process of developing an e-learning package. This will be for ward staff who'll be providing the mouth care, but also for doctors. In terms of equipment, we've been through a process of considering the cost-benefit of various tools and products. We've experienced some delays in trialling of the equipment, and as we headed into winter, we found that competing resources on our initial pilot wards, which were the COVID wards, meant that we had to rethink things slightly. However, we have been able to get involvement from other areas, such as the hospice, to help with feedback and to ensure that the project progress could continue. We've had to adapt and alter the way we are piloting the project. We've extended the timeline and we've moved parts of it to less acute settings. Over the coming months, as we complete our modified pilot, we'll continue to roll the project out to the rest of the Trust. We want to raise awareness of the importance of oral health, not only for patients with COVID, but for all inpatients. We feel that developing the package of e-learning to support our medical and nursing colleagues is going to be really important. We'll continue to monitor what is working and what is not, and continue to work collaboratively in order to improve the care that we are giving. Thank you for your time, and a huge thank you to everyone who's been involved in this project.